New Medscape Live app.
Morning, everyone. Happy, windy, rainy, kind of spontaneous weather Sunday. Hope everyone had a good journey into Atlanta. We're honored that you're here. Show of hands, who is an infectious disease doctor? What about working in pharmacy? Researchers, public health officials, educators? I'm missing a massive group, but regardless, I don't think anyone in this room needs any type of call to urgency for the fact that even though COVID may not be appearing in headlines every day, it is far from gone if it ever is going to. So thank you for joining us for this Medscape Live newsroom event as we talk about safeguarding treatment and making sure that we're doing everything we can for vulnerable populations. It is an honor to have you all here. Do I have a clicker? Yes, I do. Is my clicker going to work is the second question. So one thing I want to make sure everyone does is take a moment to scan the QR code and get onto Medscape's portal. So not only will you be able to interact directly with the slides, we want you to submit questions to try to stump our expert panelists at the end. And also, you'll be able to participate in polling, password ID week, connect to the Wi-Fi network. And just so you know, throughout this presentation, I might be jumping off stage and I might be running around in the audience with the microphone. We're all friends now. You've eaten breakfast, you've had oatmeal, you've had coffee, and we want people to participate and kind of share your expertise with us as well, your experiences and what you're seeing in your patient populations. So with that, we'll do one quick intro video and then we'll start the party.
Welcome to the COVID Countdown, the latest in safeguarding protection and treatment for vulnerable populations. SARS-CoV-2 infection continues to pose a significant threat to vulnerable populations, including individuals of all ages with underlying medical conditions and those aged 50 years and older. In addition to vaccines, post-exposure prophylaxis can help protect such individuals from complications of COVID-19. Over the next 90 minutes, we'll focus on the continued burden of SARS-CoV-2 infection in vulnerable individuals with the aim to enhance long-term outcomes for at-risk populations. We'll explore emerging preventive strategies and share current evidence about the efficacy and safety of new agents. We'll also discuss the possible clinical applications for new interventions when they become available. Join us as we navigate this important and timely topic.
Right on. So quick introduction. People are like, who is the loud person yelling from the newsroom sign? My name is Dr. Alok Patel. I am a journalist at ABC News. I work with Medscape Live, and I'm a pediatric hospitalist at Stanford University. Listen, I like bash my head on the wall sometimes because I'm like, you know who else is vulnerable? Children under the age of 1 and with underlying medical conditions. So I share this sentiment with all of you that we need our advocacy and our voices to be louder. But I will turn it over to the esteemed chair, Dr. Hayden, to introduce himself and his panelists.
Thank you very much, and good morning to everyone. I'm Fred Hayden. I'm an emeritus professor at the University of Virginia, and it's my great pleasure to introduce my two faculty colleagues. First, Alison McGeer, who's professor of laboratory medicine and pathobiology at the University of Toronto in Canada. And Alison has had experience with all the coronavirus events over the past several decades, including SARS, which disproportionately really impacted Canada with the highest number of cases outside of the Asian countries, including several deaths in healthcare workers. She's been a consultant for World Health Organization on the ongoing MERS events, and course, like the rest of us, was heavily involved with the response to COVID-19. Shmuel Shoham is a professor of clinical medicine at Johns Hopkins University School of Medicine, and he has been involved with the COVID-19 response in many ways, but also as a member of the IDSA COVID guideline committee that helps provide guidance on the use of our current interventions. So with that background, I'm just going to take you through quickly the agenda. We're going to hear from Allison really about epidemiology at present with regard to SARS-CoV-2. Shmuel is going to then deal a little bit with disease pathogenesis and start the discussion with regard to interventions, including both prevention as well as treatment. But in the midst of that, I will talk a little bit about some emerging interventions with regard to post-exposure prophylaxis, and then he'll finish with a discussion on treatment updates. And then finally, we'll have some interactive discussion with regard to some clinical scenarios. So with that background, let me then turn it over to Allison.
Thanks very much, Fred. Okay, so here we go. So the first thing to remember about COVID is how much better it is than it was at the beginning, right? So this is a CDC graph of mortality due to COVID-19 from 2020 to 2025, and you can see the really dramatic decline, not unexpected with pandemics, as both vaccination and infection have increased immunity at the population level. And if you want to think about the relative size of that, the most dramatic place to look for it is in residents of long-term care, the frailest and oldest of our subpopulations. I couldn't find any US data on this, so these are Canadian data in blue from Vancouver and in orange from Ontario, looking at the case fatality rate for symptomatic COVID cases in long-term care, which started at about 27% in 2020. Decline, you see the first decline before we actually had vaccines available, and then all the way out to 25, 26, when just at the beginning of the season in the September outbreaks, we're talking about a rate just below 1%. And you think, you look at the last and you think, well, that's not a dramatic decline, but if you expand it, looking from 22, 23 to 24, 25, you can see there's nearly been a 70% decline in case fatality over the last 3 years. So last year in Ontario was the first year that more residents died of influenza than died of COVID-19, which is like good news and bad news, okay, right? Because now we've got a disease which is not worse and maybe a little better than influenza. And the key question, of course, is it going to stay like influenza, where we're really going to badly need interventions and prophylaxis? Or is it going to continue to decline over time and become something like seasonal coronaviruses, where decisions about treatment prophylaxis may be a little bit more difficult? And here's now US data for the 24-25 season, where you can see that the number of hospitalizations and the numbers of deaths are now within the influenza range, right? Influenza's got a much broader range because seasons are available. But the estimated COVID hospitalizations and deaths are now at about the level of an active H3N2 season, our worst kind of influenza seasons. And as you might expect, SARS-CoV-2 has continued to evolve. So these now are, again, CDC data looking at the evolution of variants over time. And the great majority of isolates we're seeing now are XFG, and here's data from Florian Kramer's group looking at what that means in terms of protection. On the left-hand side, you can see JN1, KP2, which are the antigens in last year's vaccine, drifted a little bit. The first highlighted rectangle is LP8.1, that's what's in the vaccine this year. And then over to the right of that is XFG, and you can see there's a little bit of a drop from LP1 to XFG, but not dramatic. And on the antigenic cartography further on the right, you can see that LP8.1 and XFG are pretty close together, but at a fair distance from the KP2 and JN1 the year before. So this is good news that what people have chosen to put in the vaccine this year looks pretty well matched to XFG. Of course, what might happen over the next 8 months during the season, still an open question. What have we seen so far this season? It's been pretty similar across all of North America in both the US and Canada, and you can see that there was a peak in activity in September, which has declined pretty rapidly, both in test positivity and in hospitalizations. What you really want to know is, okay, so what does that mean for the winter? And this is what it means for the winter. I think if you'd asked any virologist in March of 2020 whether by 2025 we would have stable seasons and we would know what was going on, they probably would have said, yeah, they thought so. But it's just not true. So this spaghetti diagram is from the Johns Hopkins Hub for Modeling. So it's every modeling group looking at what's going to happen with COVID this season, and you can see that it's really all over the map. Very hard to predict what it's going to do. And the little gray circles are what it's actually done so far. So in terms of, there are some models that looked pretty good up until September, but none of the models depicted this really sharp decline we've seen in September. So, you know, this is really a suggestion about hope for the best, but prepare for the worst, right? I'm looking at that decline and dreaming that we might have a really quiet COVID season this year, you know, but my rational brain is telling me that we're probably going to have some kind of season sometime later in the year, and consequently it would be silly not to be prepared for the season coming in all of our patients. Okay, so then who do we have to worry about this year? And this is a standard list of people at higher risk of developing severe COVID who you need to care for: people who are old, especially those who are frail, pregnant women, anybody with significant organ system disease, and anybody who's immunocompromised either by disease or by therapy. And of course, within all of those risk factors, there's a range from the low risk green to the high risk red. So age, immunosuppression's obviously highly variable, up to stem cell transplants at the end, variation in whether you've had no vaccines or up to 8 or 9 vaccines, how often you've been infected, what your organ system disease is, with a very clear increase both in severity of whatever your underlying illness is and in the number of underlying illnesses you have. And then finally, you've also got to think about what's people's exposure risk. Not exposed to COVID, you're not going to get COVID, and it doesn't matter. And so people who live alone, work at home, are really careful about their exposures. One category of people who live in large multi-generational household, work in long-term care, have much higher risk of acquiring disease and consequently more risk of severe disease. The biggest risk, as is generally true about infectious diseases, has to do with age. And so this just shows you the difference between the rate of hospitalization due to COVID in 30 to 39-year-olds is about 40-fold less than in 85 plus. So really greatest increase is with increasing age. And that's partly, this is not adjusted for disease, so that's partly just age. And it's partly that as you get older, you tend to accumulate chronic organ system disease, and that contributes to the increase as well. So first of all, age. And then organ system disease, not as the highest risk, but as the most common of underlying comorbidities. And this graph just shows you the increase consistently, no matter what you look at as an underlying disease. When you add comorbidities in that organ system or others, your risk tends to go up. In cardiac disease does tend to have a higher risk than others, but really they're all relatively similar. And then there's immunosuppression, and as we all know, immunosuppression's become a lot more complicated with the increase in biologics that we're using. And the easiest way to look at it, I find, is to use the new IDSA guidelines that stratify higher risk, moderate risk, and low risk immunocompromised patients. And up at the top, always recent stem cell transplant or people who have ongoing graft versus host disease after stem cell transplant, hematologic malignancies. Lung transplants here, lung transplants with COVID are a little different than other solid organ transplants, and that's different with COVID and other diseases where it really does look like lung transplants have a specific increased risk of severe disease with COVID. And then solid organ transplants, current active therapy for cancer, HIV infection with low CD4 counts, and in the lower risk, stable HIV infection, end-stage renal disease on dialysis, solid tumor. And here's just the range of risks, so you can see the quantitative differences in size from the UK INFORM study, looked at a quarter of the UK population and stratified disease rates by particular situations. So early stem cell transplants have a highest risk, still lower, right, than age 80 to 30, but really significant. As you get further out from your transplantation, the risk declines. Next in line, hematologic therapy, people with B-cell therapies, people with solid organ transplant. Interestingly, solid organ transplant risks appear to stay stable over the first 4 or 5 years. And then solid tumors with active therapy, and down at the bottom, significant, but now moving into the same risk as other organ system disease, people with end-stage kidney disease, people with solid tumors who are more than a year out after cancer therapy. So it really adds to the complications of thinking about how you're selecting people for both treatment and prevention, the really wide range of increased risk that you now have to deal with.
You. I think, excuse me, not only is it important to give everyone an overview and to highlight the at-risk groups for practitioners, but also so our patients and the public know, oh, I'm high risk, I should probably go and get treatment, get vaccinated, so thank you for that. We're going to pass it over to Dr. Shoham to talk about ongoing challenges with providing care for those with severe COVID-19. I'll tell you from the PED side, the challenge is, do I call an ID consult at 2 a.m. or do I let my colleagues sleep until 7 a.m.? That's my challenge.
You can call the fellow.
That's fair, I can call a fellow. Take it away, sir.
Great, so I'm going to talk about the challenges to providing care for severe COVID, and the important things that you're going to have to know is the epidemiology in your community, and that's why the things that Dr. McGeer was talking about are so important. And you're also going to need to understand the pathophysiology of COVID. And I know that half the eyes in the room just rolled when I mentioned pathophysiology, but I'll show you why it's so critical. Next slide. Before I dive into that, I'm going to ask you guys, what are the challenges that you face in practice when providing treatment for patients with COVID who are at risk for developing severe disease-related complications?
I'm going to walk over to the hands I saw raised when I asked who was an ID doctor, because I know someone has a challenge that they want to share with us when it comes to treating patients with severe COVID. This table. Does anyone have either one of you have an opinion about challenges you run into when providing treatment for patients with severe COVID or who are high risk?
Some medications are not, there are age limit for some medications for children.
Preaching to the choir, homie. Give me a fist bump. Over here, does anyone have another barrier they run into or another challenge? Gentleman with the dapper scarf. You've got a smile on. Do you have an opinion?
I'm not a treating physician.
That's okay. It's still a dapper scarf, though. What about this table right over here? Surely, when it comes to identifying patients and risk, prescribing behavior, what you're doing inpatient. Anything you could think of that might be a challenge or something difficult. That's okay. I will toss it right back to my panelists. I agree with the assessment about age. Are there any other challenges that you feel people run into?
So for me, the biggest challenge is to identify which patient is going to benefit from therapy. And I'm going to show you a slide which will illustrate that, but I'm going to maybe make the manufacturers of the antivirals unhappy here, but most people do not need antiviral therapy for COVID, but some do. And this is a slide looking at the right patient, right drug, right time. And I'm going to walk you through this. So you have sector 1, Roman numeral 1, and then sector 3, and then in the middle is sector 2. And this U-shaped curve is the heart and soul of the pathophysiology of COVID. So some patients, like the one in sector 1, which right now in 2025 are those patients that Dr. McGeer talked about with the bone marrow transplant and the rituximab therapy, and patients that just cannot control the virus on their own. They're going to get a lot of damage caused by the virus. Their immune system may contribute a little bit, but they're going to have most of the damage caused by the virus. So the key to those patients, even if you didn't catch them early, is to treat them with an antiviral. The earlier the better, but these patients may smolder along for a long time. Anybody in the audience have had a patient with protracted COVID, not long COVID, but protracted COVID where they're just persistently positive and symptomatic? So you've seen them, and was that patient on rituximab or some sort of B-cell depleting agent?
Almost all of them had rituximab. One or two maybe advanced HIV, but mostly rituximab.
That's exactly going to be the patients that you're going to see. So for those that didn't hear, he mentioned almost all of those patients were on rituximab, and that's where you're going to need antiviral therapy and sometimes combination therapy to really knock down the virus and allow them to get better. On the other extreme are the patients that either by the time that you got to them or maybe they were just started out that way, they have a way overactive inflammatory response. An antiviral might help a little bit to, if you can say, source control the antigen that's leading to the problem, but probably not. Their body is probably doing a job that's better than most of our drugs at killing the virus. Their problem is that they're overreacting to the virus. And then you have group 2, which even in the worst days of COVID was most patients. They were either asymptomatic or they were moderately symptomatic. They never touched the emergency room, and what they were really good at is passing COVID to the other people that are in the bad groups. And early on, you had another problem where you had a high viral load that the body was ultimately going to control. But before the body controlled it, either because of their underlying disorders, congestive heart failure, chronic lung disease, they went out of homeostasis and had decompensated disease, or their immune system took over and shot them over into zone 3. So one of the most important things that remains is identifying where your patient is. And some of the things, and excuse me for this complicated slide, but the main thing I want you to take is if you're going to treat the infection in most patients, the time to treat them is early on, and because by the time that their SARS-CoV RNA level is through the roof, then it may be too late for those phase 3 people, and it may be unnecessary for the people in group 2, but it could trigger a response that shoots the person into group 3 where they have a hyperinflammatory response. So early is important, but not everybody needs treatment. I'm going to go back a couple slides. So who are those patients in group 2? So those patients in group 2 are going to be all the patients that have an intact immune system and have immunity against COVID. So patients that have had previous disease, patients that have been vaccinated, and additionally, patients that just don't have the risk factors for progression. Anybody know the story of the 3 bears, Goldilocks and the 3 bears? Raise your hand if you know it. So you want the patients that are in the baby bear category in terms of those patients that you don't need to treat. Now, interestingly, I was talking with a group from Sweden, and did you guys know that in Sweden they don't know about the baby bear story? Because I was telling them, oh, you know, it's the Goldilocks effect, and they looked at me blank. And but so, if you have friends in Sweden, it might be good to introduce them to this story. So again, early on, that's where you want to hit them. By the time that they're in the orange critical illness, the antiviral may have a role, but the main thing you're going for is controlling inflammation. And with that, I'm going to turn it over to Dr. Hayden to talk to us about how to make that group 2 even bigger, the people that are not going to necessarily need therapy.
Well, I was told you're going to take us through a discussion in just a few moments with regard to the prevention strategies.
Thank you. All right, I jumped the gun, sorry. So this is an overview in terms of prevention, post-exposure, and intervention. So we're going to look at the 3 sectors. All right, so by the time that you're done, there's going to be an exit exam on all of this. So no, this is just to show you the huge effort between industry, between government, between public health organizations, between patients that volunteered for the studies as to getting the data that we are working with. The first approach is PrEP, pre-exposure prophylaxis, to prevent infection if exposure occurs. And the first part of pre-exposure prevention, not necessarily prophylaxis, is vaccinating people. So who are you going to vaccinate? So repeat dosing of COVID vaccines among lower risk patients, the benefit is uncertain. I'm not saying that there isn't a benefit, but it's uncertain, and you're maybe not getting that much juice for the squeeze. We also know that the uptake of annual COVID-19 booster vaccination has been poor. I see this in my patients, and I treat transplant and oncology infectious disease patients, the higher risk people, and they have vaccine fatigue. Also there's groups, there's communities where vaccination is looked at with a little more skepticism than other communities. So it's important when evaluating whether your patient should be vaccinated to know about the epidemiology, to know about the pathophysiology, to know about the patient type, but it's also important to be sensitive to the other factors that are going on individually and in a community that are impacting their decision to vaccinate or not vaccinate, and to do appropriate education. And I think we've all learned that appropriate education is not me doctor, you patient, this is what you do. It is much more nuanced than that. And we anticipate that future COVID-19 vaccines will be restricted to certain high-risk groups, and as the data interacts with culture, then I think we're going to learn much more about that. And we also anticipate that study data will be required by the FDA before approving vaccines for those that are at the lower risk group, 6 months to 64 years of age, without a risk condition. These are the available vaccines that are there. They are all approved for people over the age of 65 and older, and they're all approved for younger people, providing that they have a risk factor for severe disease or more than one risk factor. And you can see the different specificities of the vaccines. All right, so what does the vaccine give us in 2025? And this is COVID data is always, it's like giving insulin. It's always like you're working backwards. You're working for the sugar that, with the sugar that you have the information, but then you're trying to make extrapolations. So this is what we know about effectiveness versus hospitalization for the 24-25 dose, not yet for the 25-26. We'll know that in the future. So 40 to 45% is pretty much what you're going to get in terms of vaccine effectiveness. That means that if you don't get the vaccine, whatever risk that Dr. McGeer was talking about, that's going to be your risk. If you do get the vaccine, whatever risk that Dr. McGeer talked about times 0.45, that's going to be your risk. So if you are a super low risk person for having hospitalization from COVID, you're going to be super duper low risk. You then may decide whether that's an effort that you're willing to make. If you're at higher risk, then you'll go to about half of that or so risk, and it's probably going to be worth doing. Other things that can be done but are complicated is pre-exposure prophylaxis with a molecule. So we used to have a lot of monoclonal antibodies that were available, but the vaccine develops resistance to it at the binding site of the vaccine to the receptor. And they've all become either useless or very close to that. Pemivibart is a monoclonal antibody that has still retained efficacy to a certain percentage of COVID strains, and the percentage that it's effective differs by the different areas of the world. If you identify a person that has moderate to severe immune compromise, either due to their underlying conditions or to the treatment that they're having, and therefore unable to mount an adequate immune response to the vaccine, you're still going to want to vaccinate them, but you're not feeling all that confident that they're going to get a response. Either they're on, they've gotten the rituximab, they're getting heavy-duty immunosuppressive medications for COVID, so you want to try to give them a little something extra, and Pemivibart could be that thing. How do they know that Pemivibart is going to work? There is an ongoing clinical trial, but that takes a long time to recruit patients and to get to endpoints. So what they did is they looked at the antibody concentration that people that got that stuff have, and then they compared whether that antibody concentration was going to be enough to control the virus. They did it both in vitro, they did it in different assays measuring the concentration of antibody that's achievable in the person, and then they compared that concentration to other drugs that were successful when they were effective. So that's called immune bridging, and based on that, the FDA felt that that was enough data to say, okay, this is going to be likely effective, providing that the virus in the community is still sensitive. In terms of toxicity, the most common toxicity was going to be infusion-related reactions. People have different reactions. About 3.6 to 2.2% rate of adverse reactions from infusion. A very small, but not zero, percentage of patients that got Pemivibart developed anaphylactic reactions. So when you give this drug, you can estimate that if you give it to a zillion people, some of them are potentially going to have the anaphylactic reaction, and that's part of the decision tree that you make in terms of whether to give it. So putting all that together, the IDSA recommended that in patients that are in the high risk and moderate risk group populations, that this could be considered as a way of preventing COVID, providing that the vaccine in your community is still sensitive to that. So who are those patients? There are those patients that we talked about that got the rituximab. There are patients that have lung transplant because it's incredibly inconvenient for a lung transplant patient to have COVID, both the direct effect and their immune system can overreact and hurt the graft. Other patients you can see in the box, solid organ transplants other than lungs, patients with graft versus host disease that's moderate, patients with HIV that has a CD4 count of 200. But if I was really going to focus on the top patients to give this to, it would be the ones in the top box. All right, so now a question to you guys. Does anybody use PrEP in this room?
Where are the primary care doctors? Any in here? Family medicine? Internal medicine? What does this table do? I'm curious. Right on. Okay, but your primary care? Oh, right on. ID. Okay, cool. This table, are you guys practitioners? Just fans. Pharmacists? You guys are practitioners? Well, you're indirect patient care, which counts. How about this? I just want a show of hands. When it comes to using PrEP in patients, who would surmise 0 to 30% of patients with underlying medical risks are getting PrEP? Show of hands, 0 to 30. No one. No one's voting for 0 to 30. What about 31 to 60, middle tier? Any show of hands? You can guess. Like I don't know the answer. Okay, we got one person. So the rest of this room thinks 62 to 100% of patients are getting PrEP. Right on. What did you say? 0 to 10. Panelists, what do you think about our very interactive audience right now? For now, you guys don't worry. I'll dial it up in a sec. What percentage of patients out there are actually getting PrEP who you feel qualify for it?
I think it's approaching 0.
You were right!
And I'm just going to see if I can take you back. So in the green, in moderately or severely immunocompromised individuals, the IDSA guideline panel suggests pre-exposure prophylaxis when predominant regional variant susceptible. In many areas, they're either not susceptible or close to it. Conditional recommendation, low certainty of evidence. So I'm not going to say that that is a resounding recommendation. And I think that it plays out in that you see a lot of patients, you're busy, and the logistics of getting them the drug may not be straightforward. And you see this recommendation, you see your patients, and it's just hard to get very enthusiastic about it.
Dimon, thank you. So now we get to pass it over to Dr. Hayden to talk about clinical evidence for emerging COVID-19 interventions and possibly moving from PrEP to PEP.
Yeah. So before I do that, I'd like to ask a question regarding another strategy that you didn't mention, and it's something that we've embraced with influenza vaccines, now with RSV vaccine, in terms of cocooning, in trying to protect those very, very high-risk individuals by making sure that there's immunization's been given to all their close contacts.
I think that creating a cloud or a cocoon of protection around the patient is very important. Where are you going to get COVID? At home. Who's going to bring COVID? One of the people that you live at home with. So that's why the slide that you had, that if you are living alone and buying all your stuff on Amazon, I don't know if they have Amazon in Canada, then you're much less likely to get COVID than if you live in a multi-generational home. And so cocooning is very important. I would also add another strategy, which is super important, is that patients are educated that when they have the early symptoms, then they get tested to find out what's going on so that early treatment can be started. And We'll see what Dr. Hayden has to say, but it might make sense also that if somebody in your home has a symptom, then they get tested as well, so that potentially post-exposure prophylaxis can be done.
Indeed. So I'm going to try to...
It's the hype music.
I'm going to talk to the issue of using post-exposure prophylaxis. This is something that's been shown to be very effective in terms of reducing transmission to contacts in the household setting with influenza. We have several agents that have been proven to reduce that risk by 80% or more. But timing is such a critical variable here, and that's true for all the respiratory viruses. And again, a lot of this work has been done in the household setting because that's where a lot of transmission has occurred historically and continues as a risk situation. I want to emphasize, though, that none of the agents that I'm going to talk about has been approved by the regulatory agencies for post-exposure prophylaxis. There are some agents that are interesting that are where there is off-label use, but we as we speak today, do not have an agent that's approved, although one is under review currently. So this comes to a key question. What patient populations would you prioritize for COVID post-exposure prophylaxis? And how do you stratify risk in the practice setting? I think we've touched on the latter to some extent, but I'd be interested in knowing what the audience has to say about this.
I'm also curious, and I'm curious about my ID squad over here, which patient populations you might be really pushing up there for COVID PEP.
I would look at your IDSA guidelines and look at the group that's in the highest risk. Rituximab for sure. Probably stem cell transplant patients would be in that group. But the highly immune suppressed individuals would probably be my key target.
This staffer table, what do you all do? Not prescribing physicians. Let me ask you all a very important question, though. Have you ever stepped on a nail? Or like cut your hand in some dirt or something like that? Did you have to go get post-exposure prophylaxis for tetanus? What determined whether or not you had to get that?
The risk of us getting an infection, right?
Right on. Did your doctor ask if you had previously gotten a tetanus vaccine or anything?
Yeah, when was the last time we got it?
Cool. So this is an educated guess. Do you think that plays into whether or not people with COVID-19 would need to get post-exposure prophylaxis, whether or not they've been vaccinated?
Yeah, absolutely. Yeah.
Right on. Cool. You all agree with that assessment? I got a great answer out of them, and they said they were not practicing providers. Does vaccine status play into whether or not post-exposure prophylaxis would be recommended?
So in terms of vaccine status, how likely the person is to respond to the vaccine, that would be an important thing. But the other group that I would add is frailty. So this was a study that was done in Japan, but I think it is applicable to here. Frail people that got admitted to the hospital with COVID had a substantially higher risk of not coming back home for whatever reason, either dying or long-term care facility, than people who weren't frail. So I think that goes into the calculation as to how important it is to prevent COVID in an individual patient and what their values are.
We don't assess frailty routinely, so you don't see a lot of studies looking at the assessment of frailty, but in influenza, frailty is as important as age, so top of the list, and it's almost certainly true for COVID as well. So I'm gonna add two other people, the people we really want post-exposure prophylaxis for, people exposed in the hospital, so people in shared rooms with somebody with new onset COVID. Nosocomial COVID has a very high case fatality rate, and long-term care homes, whatever The individual level in long-term care homes may not be important, but antiviral prophylaxis for influenza has been a miracle in long-term care homes. Just shortens influenza outbreaks, means that you don't have visitors out and all sorts of chaos for as long a time. And having COVID prophylaxis would be really, really helpful in that setting.
In the influenza setting, it's that intervention in the chronic care facilities is irrespective of their vaccine status, because we know, as was shown for COVID vaccine, that protection is incomplete at best. And so that if you're really trying to protect someone with flu, you give them post-exposure prophylaxis, or even in some cases longer term. So let me then touch on, again, some of the older studies first that have addressed this question. These were all done in household settings. The first of these was with the dual monoclonals, casirivimab and imdevimab, given subcutaneously within 4 days of exposure to the index case in that family unit. You can see a relatively large number were enrolled in the study, and the risk of COVID was significantly reduced over the following 28 days, because of course the antibodies have a long duration effect, with a relative risk reduction compared to placebo of 81%. Of course, this intervention would not work currently because of the changes in susceptibility of our variants. There was a study with nirmatrelvir ritonavir that followed on with the standard regimen given either for 5 or a 10-day course is post-exposure. Even a larger study numerically, you can see that there was a reduction. Here, there is a smaller event rate, though, in the placebo group. You can see just under 4% there. And the overall relative risk reductions were more modest. They didn't reach their primary endpoint, somewhat better with the 10-day course of post-exposure prophylaxis. And that's consistent with what we think is happening within the household setting. Most of those transmission events are within that 10-day period. Events later on are more likely to have been acquired in other settings. Molnupiravir was also studied for post-exposure prophylaxis, and here it was only a 5-day course, and it was given, it had to be done within a 5-day exposure period to that initial index case. Again, it was a more modest effect with regard to only 24% relative risk reduction in the events, but there were a lot of cases apparently that came up between 5 and 10 days, so that 5 days isn't going to be long enough. It'd be interesting to, of course, see what would happen with a longer duration in a study like that. So those are some of the older data. These are all studies that have been reported in 2025. I'm going to start with the Hezelastine one, which is not a post-exposure, but a pre-exposure. And similarly, talk briefly about the interferon study, which was also a pre-exposure. So Hezelastine is a antihistamine, which is improved nasal spray for treatment of allergic rhinitis. It does have potential side effects of sedation, as well as apparently a bitter taste. So it's very difficult to actually blind participants in a placebo-controlled trial. But in this particular study, they used it on a 3 times a day basis for, as you can see, 56 days in a fairly moderate-sized number of participants, many of whom were healthcare workers, as it turns out. And there was and they were also sampled on a twice-a-week basis to detect SARS-CoV-2, and there was a significant reduction overall in the rate of infections. In COVID was also reduced with roughly a 70% relative risk reduction. And interesting, there's also an effect on rhinovirus infection. So this is an intriguing result that I think certainly needs to be further explored in larger numbers. There had been some rationale for this provided by earlier work that showed the potential for antiviral effects related to either viral entry and or possibly inhibition of the 3CL protease of SARS-CoV-2, and one small treatment study suggesting an antiviral effect. So I think this is an agent that warrants further study and potentially could be one that could be considered for post-exposure prophylaxis. The interferon alpha story is interesting in that they really looked at high-risk patients. They focused on a group with different types of malignancies, about half of which had hematologic malignancies, and they went for, as you can see, basically a 3-month period using very low doses of a recombinant interferon alpha 2, but did see some effect. The dose that they use is much lower than ones that we and others had studied historically to show reduction in rhinovirus colds when used for post-exposure prophylaxis. And this is an intervention that I think should be looked at, but with higher doses going forward, but again, as a potential for post-exposure prophylaxis. So then finally, let me talk about the agent that I've been involved with as a consultant to Shionogi. And that's Entecavir, which is a 3C protease inhibitor, and I'll show you some more information with regards to its background. But in this particular study, the standard treatment dose that's currently approved in Japan, given for 5 days, in a large number of patients, did have a significant impact with regard to preventing COVID in the household setting, with a 67% relative risk reduction. So just some background information for you with regard to treatment, because again, this agent has been used in Japan since 2022, and I think was approved in 2024. It's approved for treating mild to moderate COVID-19. It has an interesting pharmacokinetic profile in that it has a prolonged plasma elimination half-life between roughly 50 and 60 hours. So this means that there's a need for a loading dose to get adequate drug levels on board, but it also means that even with a 5-day course of delivery, there's protracted presence of plasma levels that would be expected to be inhibitory for at least 10 days after that 5-day course. To my knowledge, there are no clinically important differences in exposure levels between the fed and fasted states, or changes with age, or any really major changes with changes in hepatic or renal function. And there's evidence from an aged mouse model of SARS-CoV-2 where that target plasma concentration was protective against disease. And in fact, that has now been validated in the post-exposure prophylaxis setting, where that level was certainly achieved out past 10 days. In terms of the treatment effects, there were significant antiviral effects documented in 2 phase 3 outpatient trials that have now been published. The figure shows the reduction from baseline on day 1 to day 4, with nearly a log difference in terms of viral RNA loads that was seen in the HR study. That study was supposed to be in higher risk, but in fact, I think only about a third of the patients had risk factors. In terms of clinical benefit, in the standard risk group, there was a significant 1-day reduction in the duration of 5 COVID symptoms, whereas in the HR study, it was a lesser effect, but a larger number of symptoms were included in the analysis. Of note, in these studies, there's been a low frequency of viral RNA rebound observed. In terms of safety and tolerability, it's been good to date in the phase 3 treatment and prophylaxis studies. I'll show you some of those data just in a few moments. no excess adverse events, treatment-related adverse events, including dysgeusia or study drug discontinuation has been noted compared to placebo. In terms of laboratory, there are dose-related reversible decreases in high-density lipoproteins and also sometimes increases in triglyceride concentrations. But again, these are reversible and have not been associated with clinical events to my knowledge. However, there is a potential for drug-drug interactions here because it is a moderately strong CYP3A4 inhibitor, and we can get back to that issue because it's an important one in terms of whether what can be used in patients that are receiving some of the classic immunosuppressive agents like cyclosporin and tacrolimus. It's an agent which has been carefully looked at in terms of treatment emergent substitutions. The commonest of these are at the methionine 49 position with leucine or isoleucine. And those can be associated with particularly the leucine substitution with substantially reduced in vitro susceptibility as indicated. In the high-risk Scorpio trial where there were 945 exposed to the drug, the overall frequencies of subsequently detecting treatment emergent variants are indicated there 1.5% for changes at position 49 and less so at position 25. In that study, they did notice that the higher the baseline viral loads, the greater the likelihood that there might be treatment emergent resistance, which is a not unsurprising result. The good news here is that it's a different pattern of substitutions that have been seen, for example, with nirmatrelvir, so that for these remdesivir and nirmatrelvir would be expected to be inhibitory. And also the clinical consequences of this are not clear at the present time. And of course, this depends on the degree of viral fitness and whether there also effects on replication or transmissibility from person to person. But in the standard risk trial, the median time to recovery was similar in patients with or without these treatment emergent substitutions. So let me just show you a little more detail with regard to the trial that looked at enceptravir for post-exposure prophylaxis, and I'm sharing slides that I presented at the CROI meeting earlier this year. This outlines a study design for you. This was a phase 3 randomized placebo-controlled trial involving nearly 2,400 household contacts who you can see were enrolled fairly recently in terms of the COVID experience. About 2/3 were enrolled in the United States, a quarter in Japan, and then South Africa, Argentina also contributed, along with Vietnam, contributed additional patients. So it was really an international study. The index patients in these households had to have a local test positive for SARS-CoV-2 and, of course, as well as symptoms. And importantly, the household contacts, in contrast to the earlier studies, which generally had to be enrolled within 4 to 5 days, here it had to be within 72 hours of the onset of symptoms in the index patients. And of course, the contacts also had to be negative at a local test as well as basically symptom-free. They were randomized to the standard treatment dose or placebo, and then monitored with frequent nasopharyngeal swabs as indicated by the asterisks out to day 28. The data I'm going to show you focus on the modified to intent to treat population. These were all the randomized household contacts who had a central laboratory confirmed negative test for SARS-CoV-2 at baseline. About 10%, even though they had been screened with local testing, 10% roughly turned out to actually be positive for virus before starting their post-exposure prophylaxis. And the primary endpoint here was the proportion of household contacts who developed COVID-19. This, again, was confirmed in the central laboratory by RT-PCR testing. And they had to have at least one of 14 COVID symptoms that lasted for at least a minimum of 48 hours, and that was within that 10-day period of risk within the household setting. This is the primary outcome in terms of the proportion of the household contacts who developed COVID through day 10. You'll notice it was in the placebo group, it was 9% compared to 2.9% within Entecavir. So that's a very significant risk ratio. So that corresponds to a relative risk reduction of 67%. In terms of the occurrence of events over time, the Entecavir group is shown in the blue. As you can see, was well protected out through day 10, whereas in the placebo group, events started taking off within several days after exposure, after initiation of study drug, and continued to accelerate through that 10-day period. Thereafter, the lines look pretty parallel as these individuals were exposed to a virus in other settings. But of note, there was really no rebound, and that the reduction in the risk was maintained out through day 28. Now, there's also, of course, a series of pre-specified analyses that we looked at in terms of subgroups to see who would benefit given the context of our discussion about higher risk individuals. I point out that in the higher risk group, which composed about 37% of both the placebo and active study groups, there was an effect seen. The risk factors here were primarily older age, 65 years and above, obesity, smoking, and to a lesser extent, diabetes and heart disease. But in that group, the point estimate of the relative risk reduction was actually 76%. So there was good protection observed in that group as well. In terms of safety, and these, again, are healthy individuals for the most part, without baseline symptoms, so it's a different question to address than someone who's already ill with COVID. There's really no differences in terms of treatment emergent adverse events between the groups in terms of frequency or type. You can see a very low frequency of serious treatment emergent adverse events, and a low rate of discontinuation. So that both of these interventions were well tolerated. No real difference between Entecavir and placebo in terms of the clinical outcomes, and no deaths or hospitalizations occurred during the study. So this agent has been accepted, the NDA for it has been accepted by the Food and Drug Administration for review for the prophylaxis indication in September. Hopefully the action date of June 16th will be sooner than that in terms of getting access to this intervention, which I think clearly does show both adequate tolerability and effectiveness in terms of the post-exposure prophylaxis indication. So, question?
Let's be a little panel discussion on this question.
Okay.
I'd be curious to hear all three of your thoughts about how you approach PEP decisions in immunocompromised patients versus those with other high-risk comorbidities. I mean, Dr. Shom, you alluded to this earlier, but I'd be curious to hear what you all think.
So for post-exposure prophylaxis, say that this drug becomes available. The key, is there a way to get rid of the feedback? Thanks. So the key issue is how much of a hassle is it going to be for me and for the patient? And let's assume that there is efficacy. So if the patient is on tacrolimus, cyclosporin, sirolimus, and I know how to adjust the dose of those, we're good to go. If it's going to be a black box where the patient might come back with tacrolimus levels that are through the roof and seizures because of tacrolimus or acute kidney failure, I'm not going to want to do it. So that's going to be up to the company and to pharmacists to be able to give us a rule of thumb saying, okay, you start this drug, you knock down the tacrolimus dose by X amount, you measure your level in X amount. One of the problems with giving Paxlovid, which was nirmatrelvir and ritonavir together, was the ritonavir. That is like a force multiplier for CYP3A4 inhibition. This is not an issue with this drug. The other problem was that you couldn't measure tacrolimus levels easily in those patients because the lab didn't want them if they have COVID. Since this is post-exposure, they don't have COVID yet, so you could send them to Quest, LabCorp, wherever to get labs drawn. So I think that those are issues that are going to need to be ironed out. If the patient is in the higher risk group for having a bad outcome in terms of immunosuppression, I'm on board.
I just comment. In the study that I described, there were very few immunocompromised hosts that were included. And in particular, those who were on agents like tacrolimus and cyclosporin were excluded because of the reasons that you've alluded to.
Right on. Well, on that note, we've gone from PrEP to PEP to possibly getting into some conversations about treatment. But before we go there, I know, listen, I'm not going to jump in the audience yet. But I do feel like even if you're prescribing or not or seeing patients, people do have some type of opinions about how cost effectiveness may influence whether or not people get these interventions. So someone just yell out how cost might influence whether or not someone gets a treatment. Someone say something. Insurance possibly? Maybe hospital, how much a hospital is actually able to get this medication? What other cost variables can people think of? Someone yell one, or I'll come down there with the microphone.
I can tell a story about cost.
Tell us over.
All right. So one of my colleagues called me and they said that she had just come back from doing a medical mission in Uganda, and now she was about a week coming back, fevers, chills, feels horrible. So, you know, you think in your mind as an infectious disease doctor about malaria, about salmonella, about other dengue, but one of the things that I mentioned to her, I said, what about COVID or flu? So she said she was ruled out for flu somewhere and that she's doing a home COVID test, and then she called me back a couple hours later and she said home COVID test is positive. So she had COVID, she was feeling horrible, she is in her 40s, and she said, what do you think about Paxlovid? I said, couldn't hoit. So so I wrote her a prescription for Paxlovid, and then she said, well, they said it would be $1,200, so I think I'm not going to do Paxlovid. And I said, okay.
Fair. I think that's a very realistic conversation we need to have. In the interest of time, I want to hear more. I want to hear more regarding Dr. Shoma about treatment of COVID-19.
All right, so we're into the purple part of the discussion, interventions after onset, and here are the different tools that we have. So moving from left to right on my screen, you have the virus, and the virus engages with the receptor, and we can inhibit that receptor both by natural immunity that has already happened or vaccine-induced immunity, or you can give them an antibody, and that antibody can be a monoclonal antibody or it could be a polyclonal antibody in the form of convalescent plasma or potentially hyperimmune serum. And if there's a good fit between the antibody and the virus, then you can get blockage of the interaction between the receptor and the virus, and then also you can decorate the virus with antibody that then the immune system will come and kill them. So the problem is that the virus is constantly interacting with the immune system of vaccinated and naturally infected people, and particularly in immunocompromised patients, the virus is not being completely eradicated, so then you have variants that are resistant to either the monoclonals, to the convalescent plasma, or to the vaccine, and then those variants from generally immune-compromised people are passed on to the community as a whole, and then the vaccine needs to be updated, the monoclonals stop working, so that's that. You can do this RDRP, which is RNA-dependent RNA polymerase. That's a viral polymerase, and just like we do with the early drugs of HIV, like AZT and the other nukes, just like we do with valacyclovir, with valganciclovir, and you can affect the polymerase. In this particular case, the RNA polymerase is affected by remdesivir, molnupiravir, and then this other drug called VV16, and that inhibits that. And then you can also do an approach with the viral protease inhibitor. So the virus is put out together as this large polyprotein, and then just like with HIV and with other protease inhibitors, a protease comes by and snips things to the right place where they need to be snipped, and then the virus can package itself and move on. The target in COVID is something called MPRO. It has another name which Dr. Hayden was using, but that's where that works. So what are the advantages of nirmatrelvir and ritonavir, sold in the US as Paxlovid, is that there's essentially no resistance to it except maybe in some very, very select situations. It kills the virus, crushes the virus. It can be taken as an oral pill, but it's got the horrible drug-drug interactions with the ritonavir. Some people also get dysgeusia. There's a mechanism as to how it affects the tongue to cause that. Remdesivir, given by IV, it was the first antiviral that was really effective, so there's still a lot of fondness in my heart for that drug, and you can give it as an outpatient for 3 days. You can give it for an inpatient for longer. Hepatotoxicity can happen. Don't see it very common, but patients that have high LFTs to begin with, we try not to give it. Bradycardia, I have never knowingly seen it, but I bet if I look back to some of the patients that got it, I'll find out that they actually had it, because if you look at populations, it can happen. And then molnupiravir, not super effective, but you know that Crosby, Stills, Nash & Young song, if you can't be with the one you love, love the one you're with. So sometimes that's the one that we love. It's oral, and it is mutagenic, so you don't want to give it to pregnant people. That's the drugs that are available. And in addition to impacting the initial course, can it bend the curve on post-COVID conditions? So the first part with that we'll ask is, how do you define post-COVID conditions? So if you define it in different ways, you may see efficacy in different ways. So post-COVID conditions, which can be really a range of things from kidney dysfunction, cardiovascular dysfunction, to neuropsychiatric dysfunction. That happens at the rates that you see here, 7.2% and 3.89 among older adults. This is a drug that, a paper that was recently published in Open Form Infectious Disease, which I think is very intriguing. So they looked at scads of patients that were treated versus double the number of scans of patients that were untreated, all outpatients, and they looked at post-COVID conditions in the treated versus the untreated. So you can imagine this huge database that they looked at. And they found that 33.7% of the patients that were treated versus a whopping 35.7% had the post-COVID conditions. So you can see it's kind of hard to get super excited for the whole population. But if you go into the specific age groups, you may find conditions where you're going to get a benefit. So the teenagers, not going to help them. The 18 to 49-year-olds, what is that? Would be the millennials, I guess. Still some Generation Z and millennials. Not going to make a huge difference in those as well. Once you get into people my age, 50 to 64, people with linebacker numbers, then you can start seeing an impact in terms of treatment. And when you get into the older group, then you can see a treatment. I tried to find out what the this is just the overall numbers in terms of relative risk reductions. I tried to find out the specific percentages to see if they're more than that whopping 2% difference, but I think because of the shutdown, the people that I sent the email to have not responded, but it'd be, because this data was generated by CDC people. But I think that what I walk away from is more of what we've been talking about, in that if you're going to get a benefit from treatment, then it's going to be the higher risk groups for progression. And so that 40-something-year-old woman that the insurance company wouldn't pay for Paxlovid might not have benefited from it very much. On the other hand, somebody who is my father-in-law's age, he's 87, I think I'd really like to get him on Paxlovid if he doesn't have a drug-drug interaction if he had COVID. All right, so now back to our baby bears. So baby bear is good, and that's the group 2. And you want people that have natural immunity, vaccine-enhanced immunity, minimal immunosuppression, maybe got pre-exposure prophylaxis, maybe got post-exposure prophylaxis. Those are the people that are unlikely to progress. Perhaps in those people with pre-exposure and post-exposure prophylaxis, you may still wish to treat them if they broke through to an active infection because they might have so many risk factors. But those are all the groups of people that I would feel much more comfortable that they're not going to get a lot of damage. They're not going to move up on that y-axis toward damage either from the virus or from an overactive immune response, because they're not going to have that much of virus to drive that. So with that, I'm going to ask you, how do you navigate decision-making process when current treatment options have contraindications or drug interactions in high-risk patients? So going back to my lady that came back from Uganda, say that she was actually a liver transplant recipient, and she called you. And how would you navigate treating her, knowing that if you put her on a combination of ritonavir, then bad things are going to happen to her tacrolimus, but also knowing that molnupiravir is maybe not the best antiviral out there? Yes?
Well, I would think that would be a good patient for outpatient remdesivir. They don't need to be hospitalized, which can be sometimes easily done and sometimes not. Depends on your institution and your outpatient IV access. But that would be my treatment recommendation.
I think that's a real sweet spot there for remdesivir. An interesting remdesivir story that happened is advocacy is so super important, and one of my friends that I've made through COVID works for an advocacy organization, and she had COVID. She knew she had COVID. She didn't have a positive test in her hand. Why did she know she had COVID? Because her husband had COVID, COVID proven. She had fever, COVID symptoms. She's immune compromised. her home test was negative, but she's like, I know it's going to be positive. And she could not get IV remdesivir where she was living because she didn't have proof that COVID was positive. So she's a real go-getter, and she emailed and contacted the FDA and specific people at the FDA, and they changed things so that it says a diagnosis of COVID, not a diagnosis of proven COVID. So when she went to, if somebody like her goes to the center now and says, I have COVID, I have an exposure, I have symptoms, and the clinician there diagnoses them with COVID, they can get remdesivir because of her work.
To make sure that we give Dr. Hayden more than 9 minutes, I'm going to turn the next question to a yes or no question for my panelists. Yes or no, antiviral resistance consideration as we expand the use of COVID-19 therapeutics? Yes or no?
Yes.
Yes, certainly.
Always.
Always. As an antibiotic steward myself, I was hoping the answer was yes. Quick polling question. I'll be fast. When it comes to paying attention to rapidly evolving recommendations, who is paying attention based on online newsletters or online, whatever it may be, online recommendations? We got a couple. What about conferences? That's offensive. You guys should all raise your hand right now. Anyway, what about just talking to colleagues? Too. So this middle group, you guys are just like, we don't care about rapidly evolving recommendations. We're staying put. I think it's important. I think all of it coalesced together is how we collectively in academia and in patient care pay attention. But Dr. Hayden, the fun part, can we please get into kind of some cases and some COVID clinical pearls?
All right. So the first case that I'd like to ask my panelists and you all to comment on is a 72-year-old male who presents to your clinic for evaluation following a high-risk COVID exposure. He resides independently but visits an adult day program 3 days a week, so there's potential exposures there. 2 days ago, all of a sudden, this male turned into a she, spent 2 hours in close contact with the daughter, who subsequently tested positive for COVID-19. So we have a definite exposure within the last 2 days. You can see the history includes type 2 diabetes, stage 3 chronic kidney disease, hypertension, some heart failure with a preserved ejection fraction, and osteoporosis. So some of the additional factors you can note here, that lives alone in this senior housing complex. And the daughter, unfortunately, even though she's ill, is the primary caregiver. She's had a total of 5 vaccine doses, but no current COVID-19 symptoms. So what's your approach?
Well, I think the first approach is to see if our audience can identify some of the specific factors that might be influencing COVID-19 severity risk. I see a head nod right here. Did you hear any factors that might make you think about the increased risk in our patient? Old age. For sure, chronic disease, old age, putting it all together. And then on that, I think we can just do a quick polling question here. What information, based on this brilliant assessment we got from the front table, is most critical for your PEP decision making? So show of hands supporting local epidemiologic data and variant circulation. Do we think that matters? What about patient-specific risk factors and comorbidities? Yeah, we got a few winners there. Drug safety profile, contraindications. We got it. This is why, listen, I can't do my job without pharmacists. Direct, indirect, industry, name it. Insurance coverage and cost considerations. I see some head nods, and all factors are equally important. That is my vote, just saying. Usually when you're taking like the SATs or something and it's like all of the above, you like kind of, anyway. So in which patient, all of you, would you be most likely to consider PEP during respiratory virus season, which I think we are currently entering? And this is probably like an unfairly easy question for this crowd, but immunocompromised patient, young athletic patient with exercise-induced asthma, hospital roommates of confirmed cases. We have this discussion at Stanford all the time. Long-term care facility residents. None of these patients, does anyone vote for that? Did you just come for the eggs? Or all of these patients? Any votes for, I see head nods for all of these patients. Right on. And then we were kind of alluding to this earlier, and we could probably get to this during the Q&A section, but considering using PEP in an institutional setting and kind of that question about hospital roommates, any thoughts, anything new with regarding to using it in an institutional setting?
I think it's very similar to the trade-off with influenza. When we get antiviral prophylaxis, you're asking whether it's better to give something for prophylaxis, or whether if you wait, you can give somebody really early therapy. And with influenza, because really early therapy is very effective, it's often a more sensible choice. So if you go back to the other case that's had a 2-hour exposure to the daughter, patient's got really significant risk factors for severe disease, but 2 hours exposure to someone is like, not likely to result in transmission. So that would be a setting in which if you've got some effective therapy, you might be more sensible to say, the moment you develop symptoms, we start you on therapy. Whereas in the setting of hospital roommates, you're more often in a setting where it might be really difficult to judge onset of therapy, and people may have multiple other things going on. Sometimes it's just simpler and easier to say prophylaxis. So I think the real value of prophylaxis is probably the same as the real value of prophylaxis for flu, which is going to be in institutional outbreaks, whether they're chronic care hospitals or long-term care, acute care hospitals. Just because if really early therapy is almost as good as prophylaxis, then really early therapy is often a better and easier choice.
Different interpretation of the question here, because I assume that this was an institutional setting where there was an outbreak ongoing. And I think we covered that earlier, where, again, the path has been trodden in terms of influenza, and you definitely would want to intervene for prophylaxis of those who are apparently well, and an early treatment of those who have already acquired the illness.
Yeah, I agree with everything that's been said, and I think it goes without saying that this would be part of a comprehensive approach toward clamping down on the outbreak or on the patient transmission with infection control practices and the antivirals.
Right on. So team, I'm gonna make an executive decision, because these questions that are coming in, I'm getting hyped up about. So if it's okay with you, we're gonna skip the second case study and go straight to Q&A. These are great. First question that we got in: should someone with pending surgery shortly get a COVID vaccine, such as heart surgery? I get this question all the time. Any specific thoughts there?
I think that if they can get the vaccine to them, if they've not been vaccinated yet this year, it would be good to get all the ducks lined up, including vaccinations, prior to major surgery.
Including flu and RSV as well.
I'm glad you threw that out there. Give me a fist bump. You're supposed to give me a fist bump.
Oh, sorry.
There we go. I was like, where's the flu and RSV? So the second question, especially relevant right now, and I don't know if we have an answer, but will ACIP be involved in recommending or not PEP therapies? Do you think up by ACIP?
I don't know that that's a immunization practice, post-exposure prophylaxis. It's possible, though, that FDA and IDSA, it's definite that FDA and IDSA will have opinions about it, but I don't know if ACIP.
It's hard to know what's going to happen with this ACIP going forward.
I sometimes see a trickle-down effect with what ACIP may say regarding the vaccine may then influence what happens with PEP. But I agree, I don't know how to put that in my mind. Here's an important one. Don't vaccines prevent low-risk patients from contracting and spreading COVID to high-risk patients? There's some semantics we can talk about in this question. Who wants to take it?
So the answer is yes, absolutely. And I think there are lots of low-risk patients in the same, they may be a minority overall, but there's still a very large number of them who would be happy to get a COVID vaccine in the same way that they get a flu vaccine because of the degree of protection it likely gives to vulnerable people around them, father-in-laws, people or who you work with who are immunocompromised. One of the challenges is going to be accumulating the data that demonstrate that it works. So I have, absolutely no issue with the critical importance of getting healthcare workers vaccinated against influenza because we have evidence in long-term care that when staff get vaccinated, residents are less likely to die. That's like incontrovertible randomized controlled trial evidence. And so mandates for healthcare worker influenza immunization are a gimme from my perspective. Everything we know about COVID suggests that that's probably true for COVID. The question is, how much evidence do we need before we say this evidence is incontrovertible? Because if we're going to mandate influenza vaccines in some way, or if we're going to mandate COVID vaccines in some way for healthcare workers, then I think we'd all like a somewhat higher level of evidence we have than this makes a lot of sense, and it's almost certainly true. So I think that that discussion is going to be ongoing, complicated by the fact that, of course, mandates have set everybody off, and everybody's a little anxious in general about vaccines and about control of transmission in institutions. So I think it's going to take us some time to get there. And maybe in the interim, COVID will become a mild enough disease that we're not willing to deal with it. But I suspect that we're going to end up with COVID vaccine mandates in the same way that we have flu vaccine mandates, because it's likely to continue to be a significant issue in hospitalized patients and people who live in long-term care. But, as with everything else with the pandemic, we're going to find out.
We're going to find out, and that has so many downstream implications for public health, healthcare delivery, and access. I think that was a phenomenal kind of concluding statement, Dr. McGeer. And to all three of you, thank you so much for taking the time. And thank you all for showing up and sharing your insights. I'm going to gamble and just hope that we have a mild COVID-19 season. I don't even know. But with that being said, please scan this QR code, earn some CME, earn some credit. Thank you all for hanging out. We'll be available for autographs and pictures and selfies afterwards. And may you all have a great rest of your ID week. Thank you.
Responding to questions submitted solely on the platform. And yes, you can claim your educational credit at the conclusion of the program. To gain access, please use your mobile device to scan the QR code displayed.